Okay, so we have a good amount of people already here, more people coming in. I'm going to start by welcoming everyone to our HIV Center Grand Rounds. It's great to be here. And in terms of our upcoming rounds, and what we have for the month of October, on October 6th, we have Florence Montplaisir, who will be talking about using patient and provider perspectives and big data to inform the healthcare transition for youth with HIV. And then our second rounds in October will be on October 20th, and it will be another rounds like today of two of our former postdoctoral research fellows. Well, current fellows, I'm sorry, be our current fellows, not our former. And that will be Red Driver, who will be talking about sexual orientation related differences in HIV risk among Black SMM in the Deep South, the N2 cohort study. And then Ohema Poku will be the second presenter that day. The title is The Safe Haven Intervention, Implications of a Near-Peer Youth-Led Counseling Initiative and Opportunities for Future Research. The other announcement is to remind people of our October 4th, our second session in a series titled our virtual interactive seminar series titled Why Behavioral Interventions Work, parentheses, or don't work, mechanism-focused behavioral science from theory selection to study design and implementation. So that's October 4th from 9:30 to 11. The first session was a big success. We had over 300 participants. So please join us for the second session on October 4th. Okay, so without any further ado, I will start by introducing our first speaker today, which is Dr. Katherine Elkington, known to some of us as Kate, who is now a full professor with us, a full professor of medical psychology and psychiatry here at Columbia University, as well as a research scientist at the New York State Psychiatric Institute. She is serving as the director of the Center for Behavioral Health and Youth Justice within the Division of Child and Adolescent Psychiatry, and is the training director of the T32, this fellowship program here at our HIV Center for Clinical and Behavioral Studies. Kate's research has centered on documenting the prevalence and correlates of and developing prevention interventions for mental illness, substance use disorders, and HIV risk behaviors in highly vulnerable adolescent populations, with a particular focus on youth involved in the juvenile and criminal legal systems. Her work has particularly recently concentrated on development and evaluation of implementation interventions to increase access to and increase uptake of behavioral health and health services in justice-involved populations. So today she'll be talking to us about reaching these high-risk populations, engaging them in HIV treatment, and its applications to COVID, which I think is very interesting, important, and exciting. So thanks for being with us, Kate, and I'll turn it over to you.
All right. So just going to share my slides.
And simply as a reminder, as Kate's setting up here, that be on mute during the presentation. There will be a Q&A and discussion period after Kate finishes before our next presentation, which will be moderated by Stephen Sukumaran.
Okay, so can you see my slides? They're not in presenter mode, right?
Yes, they look great.
Okay, all right, thank you. So yeah, interestingly, all the work that I've done is focused mostly in adolescents and young adults, justice involved in HIV, substance use, and mental health. This that I'm going to present to you today is actually none of that, because it's focused on COVID-19, and obviously during the early days of the emerging pandemic, COVID-19 was not an area that any of us had expertise in. But I'm going to talk today about how I was able to take or apply knowledge and that we had as a field generated with respect to HIV and working with vulnerable populations and applied to COVID-19. So first of all, I want to say a massive thank you to the team that worked with me on this. And I'll explain more about the mechanism and the funding, but it happened very, very quickly. And so you can see my team of really great investigators here. Alan Renee Cohol, Pete Gordon over in infectious disease, Coriana, who was my postdoc at the time, now a newly hired assistant professor, Patrick Wilson, and then Dan Winetsky, who was also one of my postdocs at the time. But most importantly, I want to really shout out Dr. Stephanie Campos, who was a project director and on the ground field extraordinaire. It was amazing what she was able to do, along with Maya Holcomb and Joushin Santos. The three were just an amazing group to get this work done in a very quick period of time. So I also want to spend a little bit of time just explaining the mechanism, because it sets the stage for the work that we ended up doing. This was a supplement that was written under the RADx UP consortium at NIH, and it stands for Rapid Acceleration of Diagnostics for Underserved Populations. So the RADx piece, or the RADx piece of it, was kind of a period of work that had happened before RADx UP came along, and that was really to promote the development of essentially rapid testing and that technology. And then this sort of next phase of the RADx consortium series was then to the goal of the consortium was to push the rapid testing out into the communities. This grant was written in the summer of 2020 while I was sitting on my bed trying to get rid of my children, because none of us had anywhere else to be. So you have to think about that, and you'll just, as we go through and talk about the approaches that we took and sort of how things changed over time, that there was so much rapid change during the course of this study. And so you just sort of keep that in mind. And when the grant was written, testing was minimal, rapid testing, and there was no vaccine. So just kind of think about that. Okay, so why did I kind of approach this in the way that I do? So we know that past epidemics and actual sort of natural disasters have shown that socioeconomic determinants really strongly influence the likelihood and severity with which that epidemic or natural disaster impacts a community. And in New York City, COVID-19 was no different. It disproportionately affected race ethnic communities that were characterized by considerable poverty, with high rates of co-occurring epidemics, particularly opioid and HIV. And this is thinking about the first wave now. So just getting over that initial first wave and looking back and lessons learned. It's really important then, as part of our ability to contain the spread of COVID-19, knowing that we weren't necessarily going to eradicate it. And even now, that's still not something that's likely on the cards. So it really needed to focus on identification of infection as a way of containing the spread, and thinking of that to really focus on highly vulnerable underserved populations. And for this particular study, we focused on those who use opioids and other substances. So, before COVID came along, there was a lot of focus on the opioid epidemic, and still is, and that focus was still there, but obviously sort of COVID superseded it. But unfortunately, that opioid epidemic was still going on in the context of COVID-19. And so so particularly the reason why we focused on individuals who had who were using opioids and in a problematic way. These individuals are at risk for a couple of different reasons. First of all, they may have poor respiratory health due to their substance use, and may make them more susceptible to the really negative effects of the virus. Also more likely to be incarcerated or recently incarcerated, or to reside in shelters or private living accommodation, which would further increase their risk of infection. And this was combined with limited access to healthcare and also a deep distrust of health systems. And so this would all serve to exacerbate their risk and their vulnerability. And so really thinking about how we could best access this population and really engage them to consider using rapid tests for COVID-19, and then as a stepping stone, thinking about that cascade as a stepping stone to getting into care, we thought about using social network strategies. And so these are ones that we know they've proven efficacious for accessing hidden populations, particularly people who inject drugs, and engaging them in testing and treatment for things like HIV and hepatitis C. So thinking of sort of the popular opinion leader work, sort of groundbreaking work originally by Kelly, the chain referral work by Carl Latkin, and I'll explain both of those in just a second. But the thought here was that these approaches could both be useful in engaging vulnerable populations, but there's differences in the approach, and so it was worth testing to see if there's a comparative benefit of either effect over the other. And so that's what we set out to do. And so I probably don't need to do this for this audience, but I'm just going to quickly review. So credible messenger, also known as popular opinion leader. These individuals are people with similar lived experience who are known within the target community and can connect with and motivate community members to engage in that health behavior. Chain referral, it's similar to RDS or snowball sampling, but really it has a motivational and kind of behavior change component to it as well. So study participants are trained to encourage peers among their own social network to engage in a health behavior, and so they go out and move through their social network in that way. So the study goals, as I noted, we wanted to first of all adapt these two strategies to support COVID-19 testing uptake, adapting existing efficacious social network-based interventions. And then we wanted to examine and compare these approaches on reach. So how many folks were they able to kind of get to and talk to and try and engage in some sort of behavior change around an increased motivation around COVID-19 rapid testing. And then ultimately, how did that convert into testing uptake? And particularly targeting individuals who were using opioids and other drugs. So this is the project timeline. So going back to the grant mechanism, the way that it was written was that it was a 2-year project, but the bulk of the funds had to be spent in year 1. That was sort of, and the reason is that the funders, NIH, really wanted folks to do this very quickly, to get out into these communities, to push COVID-19 rapid testing into the community quickly. And so that in that second year, it was really focused then on sustaining, hopefully efficacious programming that had been developed. And we also required having partnerships with community-based organizations so that you could really move into communities that you were wanting to work with. And so here you can see we had a very brief phase of sort of adaptation and development. We generated a working group, our CAB, and then we went into the implementation phase of the study. And so we had 2 sites that we worked with. And in the first site, they rolled out strategy 1, and then the second site rolled out strategy 2. And if you think about the first sort of phase of this, it was a Pdsa cycle, because at the end of 4 months, we huddled, we came together, we looked at what we've been able to do, looked at the data, determined whether or not there were any changes that we wanted to make or any adaptations to either strategy, and then we switched. And so then site A implemented strategy 2 and site B implemented strategy 1. And then we did the same thing. And the idea is then we presented the findings to the agencies, and then they would continue which program either was most efficacious or fit with their workflow. And now we're in the phase here where we're working with the agencies to try and generate their own funding so that they can support the testing programs that we established. Just want to start here that at the very beginning, almost outset of the project, vaccines became available. And so that was all anybody could talk about. And it felt like for a hot minute that the project was actually maybe not gonna be so relevant, and that we really needed to focus on vaccines, and testing wasn't necessarily going to be necessary anymore, or really wasn't where we needed to put our attention. And as it turned out and things sort of moved through it, we required both, and so we were able to persist. Originally, we just wanted to propose any uptake of testing, and that was what the grant originally proposed. But working with the team, and this was something that Pete Gordon proposed, was that we really wanted to, ideally, COVID rapid testing should really be used as part of it. And so something that you would do a couple of times a week, and because of its low sensitivity here, this would be, and this was based on a model that was presented by Mina et al. In the New England Journal of Medicine. This is the sort of the level of sensitivity that you would get from a rapid test versus a PCR, which is a much higher level of sensitivity. However, PCRs, you do them less frequently. The results obviously take a little bit more time to get back, whereas a rapid test, you can do them as often as you like, and the results are, within 15 to 20 minutes. And so the idea being is that if you consistently test yourself frequently, that you may be more likely to identify infection, and so could then engage in isolating behaviors much more easily and effectively than you would if you were less frequently and using PCR. And so the reason for a rapid test would then, to be really effective, would be to then have it and have people use it frequently. And so we were looking to not only see if folks would do a single test with us, but would engage in a regimen of testing twice a week for up to, the project was just to do it up to 4 weeks. The community partners that we worked with, many folks may know who these agencies are, well established in the communities where they have their sort of physical bricks and mortar, if you will. August Community, which was centered up in the Bronx, and then Alliance for Positive Change, which was, they have a couple of different locations, but we used the one that was on the Lower East Side. Both of these communities have these agencies have long-standing roots in their communities. And importantly, both have peer programs and peers that were out in the community doing work around HIV, substance use, and homelessness, but obviously not with respect to COVID-19. But they had peers on site that we would be able to kind of task shift, if you will, and apply their skill set to COVID-19. And so the first phase was the development phase, and where we needed to generate our strategy, and particularly, obviously, social network interventions, sort of loosely defined as we're using here, where the whole point about is messaging, is how do you talk to people, right? How do you get folks to engage and to speak with them and increase their own motivation towards engaging in a health behavior, in this case, COVID-19 testing. So we took a participatory action research approach, and we assembled our community action board, or our CAB, comprising peers from both CBOs, staff from the CBOs, and then participants from those CBOs or clients, individuals with lived experience who either were in recovery or maybe even actively been using opioids. And then also the research team joined as well. We had a series of meetings where we really explored, based on and listening to the community members, what they thought were the barriers and the facilitators to COVID-19 among their community members. What were some of the concerns and beliefs or misconceptions around COVID-19? And we met over about 5 or 6 different meetings initially, just to try and figure out what were some of the barriers and facilitators. And some major themes emerged from those meetings. First of all, the big thing was this sort of the idea of the infodemic. So if you remember back then, COVID-19, we were learning very quickly, and what we were learning was oftentimes changing, or it might sound contradictory. And so a lot of people on the CAB were just very confused. And with that confusion, kind of related to point 2, was a lot of distrust and not knowing whether or not what they were hearing was really true. The idea of the experience of medical racism and deep systemic distrust was definitely highly prevalent along this group. And so not only was the information confusing, but for them, really, they questioned the motives. And that was particularly true for vaccines, because we also talked about that as well. There was also a lack of resources to support services, or being able to know how to access those resources. So if you were positive, what could you do? In some instances, it was hard for folks to isolate. And so just really understanding what were some of the things that they could engage in, and maybe not knowing that you were positive might actually be better. And actually, interesting to me, I was not expecting this, but there was a great deal of stigma at that time around having COVID-19. And sort of the sense of the community that they should not have gotten it, that they did something wrong. And so an embarrassment about that. But then there was also considerable fear. I mean, these folks had all lived through the first wave. Many knew people who were either very, very ill with the illness. They themselves may have been very ill with COVID, or knew people that had family members and friends that had passed on. So thinking about how to address some of those things, we discussed that the idea of really increasing access to reliable, consistent, clear information, and that would be provided by the vectors, the peers that could be the vectors of that information. And so that would require us to really effectively educate the peers. provide normalization around testing and rapid testing in particular, and also incentivize testing uptake, and not necessarily from a monetary perspective, but that question, why bother testing? Why should I test? And so we really thought about ways in which we can promote testing as a positive way, sort of protecting family members, protecting your community, and really kind of honing in into that sense of belonging that we thought we might be able to be particularly effective. So the message delivery types, obviously we needed clear information around COVID-19 and risk reduction or approaches, what works, what's safe, testing encouragement, why test, and then also to the communication of the testing process. So rapid testing was still sort of reasonably new, and so again with that fear piece of kind of treatment and or services related to COVID, so really explaining that rapid testing was really pretty painless. And this is just a description here. So following the cabs, we generated our sort of messaging through a series of sort of infographics, as well as we used some cartoons about the testing and why rapid test, and sort of put it in story format. And then obviously we provided just some information about the project and the agencies that we're working on. In addition to generating these materials, we also then trained our peers. We trained them not only to go out into the community and sort of deliver the messaging and speak to people about how to, the importance of COVID testing and how to stay safe, but also how to train, the peers could then talk to people that came in to be tested, so that we could encourage them to go out and talk to their own peers in their own social networks and get folks to come back in. And that would be part of the chain referral arm. In addition to that, the peers were also responsible for the testing programs on site at both agencies. So we needed to teach them how to test, but also teach them how to train other people and to test and make sure that it was done correctly. And so that we had these 2 testing sites that had been set up de novo, both of these agencies that were run by trained peers who were periodically out in the community and periodically on site delivering testing. And it was a daily occurrence. And that entire process, again, Stephanie, Maya, and Xiaoxin, we could not have done that without you. And we did this in 4 months. It was very fast and very quick. And so COVID Warriors was born, and the peers wanted to name themselves. They felt like they were armed with information to go out and that they were indeed warriors. And so off they went. We had a logo and obviously a t-shirt. Every program needs a t-shirt. So what did we find? Again, so just the inclusion criteria for the folks that we wanted to come in, they needed to be 18 or older, opioid use in the past 6 months. The way that we structured the different arms, the credible messenger incentives, we did not incentivize anybody for testing, but we did a baseline or just a single one-time survey after folks had tested with us. And so we reimbursed people if they wanted to do the survey, we reimbursed them $20 for that. And then we gave them Metro cards for repeat testing visits so that they would come back and test with us. And provide the ability to do that. For Jane referral, it was the exact same thing, except that when the individual came in for testing, they were then following their kind of conversation with the peer about how they can go out into their own social networks and get folks to come back in for testing. They were then given 3 coupons. And once those coupons had been distributed, when that individual came back and said, hey, Kate came and told me that, it's really important for me to get COVID testing, so here I am, and here's my coupon, then that was redeemed and $10 then went to Kate for a successful recruitment. So just some demographics about peers on our chain referral, our seeds in each arm. So we had about 9 peers. They were split male and female, about 50 years of age. Majority of the sample, as well as our peers, were either African American or Latinx, or both. The chain referral, I had 15. We had to replace some, and I'll show you just in a moment, because the seeds sort of didn't go anywhere and they died before we were really able to get recruitment going. So we replaced them, and we still ended up with about 8 or 9. These were just some evidence or some pictures of where the peers conducted their outreach in both the Lower East Side and in the South Bronx. We did not tell them where to go or what to do. They, as I mentioned, they were peers. They were used to going out into the community, working with people who were using substances, using opioids, and getting them to engage in various health behaviors. So they knew where to go. These were their communities, but these are just some examples of the places where we went. So parks, bridges, underpasses, and then just specific areas as well where they knew individuals would congregate, specific sort of urban areas. And here you can see this is just a cumulative plot over time of, this is days at the bottom here, comparing each arm. Green is the chain referral and orange is credible messenger. And here we can look at the number of people that were either approached by the peers or the number of coupons that were dispersed. And so what we saw is, and this isn't particularly shocking, we were able to reach about 1,000 people over an 8-month period of time. And the chain referral arm had a significantly higher rate of outreach compared to credible messengers. So more folks and quicker in the same period of time. And then we've just recently finished this project, first of all. So we've just started to look at these data. And this is an initial sort of deep dive into the chain referral arm and just looking to see what were the social networks that we were able to kind of break into and just looking at some of those patterns. And then this is an example of some of those data. And you can see some of the seeds that sort of died on the vine here, or they gave out their coupons and then that was it, nothing happened. These individuals right here came in and they came in, but they actually decided not to test. And we have a couple there as well, which is interesting. So but this is just to kind of show you we were able to successfully break into some social networks, and then it was harder in others. And we're going to do more sort of more detailed analysis and looking at some of the differences across seeds and folks that they were able to convince to come in. We're also in the process right now of doing some qualitative interviews to particularly explore this experience of the seeds and individuals that were in the chain referral arm about their experiences talking to people in their own social networks and encouraging them to come in. Now, when we look at comparing testing uptake though by strategy, here we see a flip. And so we look at just looking at the ability to kind of convert that outreach into behavior change or testing. You see that the credible messenger people that was recruited by the credible messenger arm were about 1.7 times more likely to come in and test than those in the chain referral arm. We did not see any differences in the sort of the testing regimen. So looking at those who tested 2 or more or 4 more times with us. And in fact, you can see here that this was low in general, and getting people to come in for repeat testing was something that we definitely struggled with. Just demographics of the participants that we then sort of enrolled and tested, about 486. There were very few differences based on arm. The ones that are there, we saw in age. The chain referral participants were slightly older, and they were less likely to, more likely to have a high school diploma, but otherwise very few differences. Again, majority were Black or Latinx. The majority had a substance use disorder self-report. Over half used intravenous drugs. A lot of them used heroin daily. But interestingly, here you can see that actually a large chunk had at least 1 dose of COVID vaccine, which was surprising to us. And the majority had been tested for COVID before. And so I think this just speaks to how good New York City was at kind of like rolling out that vaccine and getting vaccine coverage. So in conclusion, thinking about the original question of, what test is, which approach is better? Well, it depends. We know that chain referral had a broader reach of high-risk individuals, so we were able to reach more people and have them and talk to them about the importance of COVID-19, of testing and staying safe. But the credible messenger approach, it seemed like the peers were better able to engage those that they did reach to actually kind of uptake COVID-19 testing and to engage in behavior change. Possibly peers were able to foster trust, address misinformation, and sort of do a better job educating people in the community to achieve testing uptake. So these were well-trained peers, and again, this was a skill set that they had finely tuned over the years, and it made sense that they were maybe more superior, if you will, in the ability to get people to come in and test. But the peer experiences generally highlight the potential to use community and peer-based approaches for other populations that are at high risk and hesitant for getting tested for COVID-19, or not just testing, but really now the vaccine. I just did some analysis on my move-up sample. So this was the 18 to 24-year-olds. We followed them during the COVID period as well. And we interviewed them before the vaccine really came online or was widely available, particularly to people of that age. And most of them said they wouldn't get it. A year later, we interviewed again, and 75% still had not received the vaccine. So despite we have good coverage, vaccine coverage in New York City, there are definitely pockets and populations that we need to pay attention to. Repeat testing in the COVID landscape, it was hard to do to get people to come in. Obviously, the COVID-19 rapid testing is designed to be done at home. And so I think the idea of having, if we'd given folks tests and said, okay, hold on to these, take these home and rapid test, we might have had more success. However, it's really important to think about though that COVID-19 tests are not cheap. There's about $25 for two. And for these individuals, if you're supposed to test yourself, and for certain populations and communities, testing yourself twice a week, during a surge, for example, which we would ideally want people to more actively test so that we can control the spread during surges. That's $25 a week that they have to spend on testing, and that's probably for a lot of them just not an option. So just as we made condoms available, and I know that DOH is certainly doing that. My children came home from school yesterday with 4 tests apiece, and that apparently we're going to get every month. So, but I do think that we need to more actively make testing, free testing available so that people can pick it up and take it home. We did not identify a lot of positive cases. So of our 483 people, there were only 6, so about 1.2% who tested positive for COVID. That was really surprising to us, given the population and where we were. And so we have a couple of kind of thoughts about that. One is that, over half were vaccinated. And so maybe we were not necessarily reaching a population that was most disconnected from care. But also we were doing this during, and so I have this kind of like compared to the rates that were, I know it's a different rate of infection, but the rates in New York City were going up and down. We did this during the end of Delta, and then there was a lull, and then Omicron came online. And so at some point we had to actually even shut down because there was at the agencies, the rate of infection was among the staff was so high. But still we had low rates, and some theory is that maybe a lot of this population had been exposed to COVID during the first waves, that March 2020 period of time, and perhaps that first strain of COVID was really quite virulent, and they generated antibodies that were still protecting them sort of 10 months later, a year later. Also too, one theory is, as I mentioned, over half of them used injection drugs, and they had a small they described small networks that they sort of used with, and so they were potting inadvertently, and they may have just protected themselves in that way because their social networks in that way were quite small. But just to kind of finish with the idea that unfortunately, COVID-19 isn't going away. There's definitely concerns that there'll be stronger strains are on the horizon, or just new viruses that we will experience in the similar way in new pandemics. And I think that we have experience with HIV and over 30 years of experience really working with communities that are particularly vulnerable and helping them to protect themselves from the effects of an epidemic. And I think that we can take that knowledge and we must take that knowledge and apply it to these emerging epidemics and sort of move from one silo into the public health sphere in this way. That's it.
Thanks so much, Kate. That was a lot of great data that you presented. A reminder to our attendees, if you have a question for Dr. Elkington, you could enter it in the chat and I'll read it on your behalf, or you can use the raise hand feature and I will unmute you. Kate, it looks like we have a question from Claude. Claude, go ahead.
Hi, Kate. That was really fantastic. And I won't go on and on about how fantastic I think you are, but thank you for sharing that with us. And I have so many questions. I'm going to focus on one administrative one, but I'm sure you're going to be looking at your data in terms of maybe the mixed messaging that's out there, you know, when our Democratic president says the COVID pandemic is over. And, you know, that's one area, and also social determinants of health and where that might play out in some of what you have. But the question I really have for you is, it's amazing that you got this done so quickly, considering what it takes to get through IRBs, you know, grant administration. And for those of us in the audience, you know, do you have any advice on that? Because I'm so impressed. You know, it's not surprising that you got your on the ground people motivated and moving, and I know you had an incredible team, but just how you move things administratively. Sorry.
Yeah, no. So I mean, I think so. One thing was that the grant was written, like I said, sort of in the summer, and was funded like 2 months later. I mean, it was very, very short turnaround. So that was one thing. But then we were part of this larger consortium, and there was a lot of pressure from the consortium for us to kind of move through and do what we said we would do. They didn't want people to kind of dilly-dally. And so I took that seriously. And I guess we just, I mean, I have a great team, and we were able to write the IRB. I think that there was a lot of, I don't know, goodwill is maybe the wrong word, but people knew that, like, we at the time, and it's hard to think back, or maybe everyone can remember, like, we were very aware of what was happening, and kind of the dire situation, and the fact that what happened in sort of March, April, and May wasn't over, and it was gonna, you know, it was going to continue to happen, and these new surges were coming. So I think that the IRB worked with us really, really effectively and nicely. I mean, I sit on the IRB, so I also know, like, how to put a protocol together. That I know some now well, like what some of the pitfalls are and where you can get tripped up. So we were able to do that, and the CBOs were fantastic, and we were just able to, you know, we didn't start straight away in September, October time, and in part because the COVID was up and there was some concern about whether or not we could be in the field. So we had to remove everything, at least for all the CAB meetings. Well, not all of them, but the early ones were all remote, all via Zoom. So we had to set that up with our CAB. So it was just, I think at that point, it was just a real can-do attitude, you know, and we were all just sort of mucking in and in the trenches and really feeling like it was important work. So we just made it happen.
Thank you. And so to everybody at the HIV Center, Kate just admitted that she really knows how to work with the IRB. So we know who our go-to person is now.
Absolutely, no, seriously, absolutely. Come talk to me.
Great. Thanks, Claude, for your question. We have a question from Susan Tross. Susan says, amazing, quick, and meaningful work. You may have discussed this, but what was the training for the seeds?
So the seeds, we train them in a similar way that we would have trained them if they'd come in and to redeem a coupon. And so the peers had, that's actually a really good question. So the peers had pretty extensive training. In part, actually a lot of the peer training focused on how to do testing safely and what happened if we had positive participant, and kind of cleaning the area and all that business. And the testing was done outside, overwhelmingly outside. And then they had a sort of a couple of hours training over, I think, 2 or 3 sessions about the messaging. The seeds and then the participants, so their training was kind of on site, and it was part of a conversation that the peers had with them, and so with the seeds as well. And so it was much less, and I think that's a really important point. And it was maybe, you know, kind of like a couple of hours, and the way that it happened on the ground. So we had our initial seeds. They went out and kind of instructed to go into their own social networks. Those folks then came back, and the same process then happened. So the peers then spoke with the people that they were able to get to come in and redeem their coupons and get tested. But it happened during that single testing session. And our hope was that we would continue to educate them and work with them when they were coming in for repeat testing, was the goal, so that the dose would be pretty similar to what the peers originally received with respect to kind of messaging and how to motivate people and engage people. But that didn't happen because folks didn't come back in. And so that's definitely something that we kind of struggled with on the ground.
Thanks, Kate. We have another question from Yi. They write, hello, thanks for this wonderful presentation. You said you were surprised for the fact that there weren't many COVID positive cases in the study population. I'm sure you did look into it, but have you looked into their employment status as well? Perhaps they were less likely employed, hence less likely to interact with others, and also was avoiding crowded areas in general. Just a thought. Thank you so very much.
So yes, and do I have that? We do have that data, and I think that there was, you're right, a large chunk of the sample were not employed, and I do think that they may have been engaging in just naturally sort of, as we said, podding, right? Just having a smaller group of folks that they were interacting with. So that's definitely something that we can look into as well. And that's one of the things that we want to do when we do a deeper dive in the chain referral arm, just to really kind of see how these networks kind of were constructed and who was in them.
Great, thanks, Kate. Any other questions? Otherwise, Bob, I'll turn it back to you.
Great, thank you, Stephen, and thank you, Kate. That really was great, and yeah, like Claude said, pretty amazing the way you conducted this work and the time that you did and all of that. So good lessons for us all, and thank you for making yourself available to those of us who could use IRB advice and guidance. Okay, so now let me move on to introduce our second speaker, Tanya Taylor. It's great to see you, Tanya. Thank you so much for being here. I understand you've been feeling a bit under the weather, so we really appreciate you making the effort to join us today, nevertheless. Tanya Taylor is, as well as the whole session is, she was a former postdoctoral research fellow with us at the HIV Center. She is now an assistant professor in the College of Medicine and Special Treatment and Research, the STAR program at SUNY Downstate Health Sciences University. She's a co-investigator in the MAX cohort, the multi-center AIDS cohort study, Women's Interagency HIV study, so the MAX and the WISE studies, that many of us know it as, this combined cohort study, and she's co-director of the Brooklyn Initiative to develop geriatrics education program at SUNY Downstate, known as the Bridge program. She has over 24 years of experience in design and implementation of ethnographic, survey and qualitative research in the United States and Southern and Eastern Africa. So she's here today to present preliminary findings on a new DOH Public Health Solutions funded initiative to embed geriatric assessments and an AIDS-friendly approach in HIV primary care. Thank you for being with us, Tanya. It's great to see you, and I'll turn the floor over to you. You're on mute still, Tanya.
Sorry. Good
Okay, now
morning.
you're not.
I've taken about 6 COVID tests in the last couple of days. But whatever it is, wear your mask because other stuff is going around. First, I just want to say thank you for this opportunity to come back home and to present. I quickly looked at the other participants, and I just really like to shout out to my scientific mentor, Dr. Susan Tross, and I saw Curtis was on there and other colleagues that I've worked with. First, I just want to clarify that this, although I mentioned in the title pilot study, this is not a study. This is a service grant. And so it is, I've rephrased my title here to more accurately represent the fact that this is a service grant. Excuse me, I'm gonna try to get it together. So these are the preliminary findings from the Be Into Health pilot project sponsored by Public Solutions and DOH. Let's see if I can get through this, folks. I would like to acknowledge our funding sources, of course, from the New York City DOH and Public Health Solutions for the the service grant. And I would like to also acknowledge that this presentation is also supported through my work with the Bridge program through HRSA and HHS. I have no conflicts of interest. But before I start, I really have to acknowledge sort of my main mentor who has guided me throughout this journey in terms of developing expertise around aging and HIV. This is Dr. Stephen Karpiak, who died last year. And if anyone is familiar with HIV aging research here in New York, you know that Dr. Karpiak was the pioneer of the first study on older adults with HIV. It was called the ROA study. It was published in 2006 with ACREA. And this study included just shy of 1,000 older adults in New York City. And there were 6 key areas that were explored. This was a cross-sectional study for demographics, health status, sexual behavior, sexual networks, stigma, and psychological resources. The key findings are that folks, the majority of older adults in New York City, 70% live alone. Consequently, they found that there are a lot of fragile social networks and also inadequate health care that combined have resulted in substantially higher rates of depression with our older adults in New York City. The ROA study, I just want to mention, is continuing with ROA 2.0. First started with our study in San Francisco, Oakland, and upstate New York, and I believe it's also in Chicago. And we're really excited. And I believe there are going to be a total of 3,000 older adults in that combined second phase. ACREA and under Steve's leadership was really pioneering in terms of, in particular, trying to address ageism and stigma, or the dual combination of ageism and HIV stigma, with really pioneering campaign messages such as "Age is not a condom" campaign. If you saw it in the bus kiosk, it was amazing. I also want to add, since September 18th is passed, that was National HIV/AIDS Aging Awareness Day. And Steve was one of those individuals who helped bring this incredible, important awareness day into existence. Steve's legacy right now is connected because ACREA then merged with GMHC. And so Dr. Karpiak created this National Resource Center on HIV and Aging. And it's available on site on GMHC's site, and provides a lot of information for clients and consumers, and in particular with a focus on long-term survivors. Please remember this lovely face, because you will see him again. So the one thing that Dr. Karpiak was, I believe, really instrumental in driving within sort of the field is highlighting the fact that there is enormous ageism in HIV research. And this has had a profound impact on care and treatment. These are quotes from Steve that were taken from interviews and published in his obituary. And his quotes are really powerful, highlighting sort of the impact of ageism in HIV research, and the fact that PrEP and PEP were only really marketed to younger people, and that the focus for a lot of long-term survivors is that we're virally suppressed, and so I guess we're done, and that nobody really cares about the fact that our lives are being challenged. So, and I think that that is, you know, the big contribution that Steve left us, was helping us to squarely identify the role of ageism within HIV research. So again, the emphasis on young adults and high risk, primary prevention for those who are at risk, but the consequence is that the long-term survivors feel abandoned. And, you know, Steve concluded we gave them a pill and then said goodbye to them. Ageism, I just want to define here as a systematic stereotyping and discrimination against people because they are old. In 2013, I became a William Butler Fellow at NIA, and this is one of my key foci in terms of doing HIV and aging research, and just aging and health disparities research is to address ageism. It permeates the attitudes of medical providers, the mindsets of older patients with internalized ageism, and the structure of the healthcare system. So this presentation is really kind of talking about the ageism that is unfortunately inherent in primary HIV care. I'm going to get through this. Just briefly, it's not just us here in the United States. We tend to only think about sort of aging in older adults in the US, but I want to also remind folks that the majority of older adults with HIV are in low and middle income countries, 8 out of 10 older individuals. And that 13% of all the people living with HIV globally, and that's 4.2 million people, are older adults. This is an old infographic, but I think it's really important to kind of just sort of see the changes over time. Right now in 2022, we don't, I don't think the statistics have really said that we have reached this threshold of 70%, but here in New York City, absolutely. New York City and some other sites in the South and California have been leading sort of this graying of the HIV pandemic. Challenges to aging with HIV. Despite access to efficacious treatment and high rates of viral suppression, older adults evidence a significant burden of disease, polypharmacy, social isolation, and depression. This burden is characterized by high frequencies of non-HIV related comorbidities, such that multimorbidity is the rule, not the exception. These multimorbidities include cardiovascular disease, hypertension, diabetes, dyslipidemia, inflammation, osteoporosis, cancers, and other geriatric and syndromes such as frailty and cognitive dysfunction. But these challenges do not exist by themselves. These aging-related stressors that include chronic illness, including, the accumulation of all other comorbidities, changing physical function, poorly managing these comorbidities or multimorbidities, polypharmacy, and more importantly, social losses around the age of 50, is when, unfortunately, we start to lose family members, parents, peers, and combine, as well as adult children moving away. And this combine has resulted in diminished capacity for self-care among older adults. For many, these stressors are exacerbated by social determinants of health, poverty, unemployment, housing and food insecurity, etc. And these poor health outcomes have directly impact retention in HIV care, as well as optimal adherence for these vulnerable older adults. The other big problem here, guys, is there is a growing shortage of geriatricians in the United States. This is not new news. We've known about this or folks have known about this for decades. But this is a problem. In 3 years, I believe the very youngest baby boomer will be eligible for Medicare. And so we are really in a pickle. And I've always felt that older adults with HIV are the canary in the coal mines, that we are going to really see the huge burden that caring for our older is going to have on the healthcare system if we look at our older adults with HIV. I didn't mention this before in the summary of the ROA stuff, but Dr. Karpiak found that older adults, older adults 50 years old have 3.3 more comorbidities than a seronegative older adult who is 70 years old. So there is a profoundly larger impact in terms of comorbidities. Another problem is within primary HIV care, most providers don't have adequate training nor the time to address these emerging geriatric syndromes such as falls, frailty, delirium, sleep disorders, incontinence. Sadly, I found that someone in my clinic, like with a request for help, patient requested help for incontinence, and they just prescribed Depends, as opposed to sending them to a urogynecologist to really address the underlying issue. So it is a problem. And older adults have medical and psychological needs that extend beyond primary HIV care, and very few HIV PCPs are equipped to understand the complexities and the biopsychosocial needs of these older adults. And then finally, the social support services in HIV clinics are being increasingly challenged. They're having to deal with elder abuse and other aspects of disability and with cognitive impairment that are new and increasing. So the Building Equity Intervening Together for Health, or Be Into Health initiative by DOH and Public Health Solutions, their mission is to address the health inequities due to all of the isms and obias, but that with a particular focus on those that contribute to HIV health disparities among Black and or Hispanic or Latinx groups. So the Be Into Health program is not just for older adults. There are actually 5 different mechanisms, and we are one particular service category. Every year there are 5 contracts, and each contract is required to implement an evidence-based intervention for that priority population. We are category number 4. And the goals of Be Into Health program are to improve linkages to HIV medical care, initiation of IART, engagement and re-engagement or retention in care, and viral load suppression. So again, the category, our service category are older adults, Black, Latinx, and Hispanic older adults. And the intervention that is being used is basically an adapted form of the Golden Compass program that was developed by our colleagues in UCSF, which is basically a multidisciplinary care coordination model. And DOH has modified that by including 2, I think, very important additional components around social activity and physical activity. These are a list of the things that we are obligated to do. Annual STI and HC screenings, biannual screenings, and this is really sort of the core of the geriatric thing. We are to do implement these 5 core assessments. They recommended the MOCA, PHQ-9, the CATS Index for Activities of Daily Livings, or ADLs, a medication review, and a fall assessment. And then they later added, which I think was also very smart, quality of life. We do monthly case managements. We do monthly case conferences to discuss the care plans. We do monthly and weekly client-centered, monthly and weekly client-centered activities, both physical and social. And of course, we're monitoring and evaluating. So I just want to say that with this grant, I have applied numerous times to try to implement this project through NIH, and I wasn't successful until I applied for this HRSA, or for this DOH grant. And I must admit that there's not on the surface a lot of aging focus or expertise. And so I just want to quickly map out how our project is a little different from the other 3 projects that are ongoing right now. So first and foremost, our project is guided by an age-friendly 4Ms framework. This is a framework that was initiated by the John A. Hartford Foundation and the Institute for Healthcare Improvement, along with American Hospital Association and others. So the 4Ms framework, this is basically a distillation of sort of all of the critical things that we need to do in order to provide optimal healthcare to our older adults. And they worked from a very large list and distilled it down to 4 M's. What matters: medication, mentation, and mobility. What matters is knowing and aligning the care of each older adult with including their long-term care preferences, which include end-of-life care. So it's really important. We have to start with what matters most to the patient. Medication, of course, deals with polypharmacy and, trying to deprescribe, and also looking at polypharmacy and its impact on other M's, such as mobility and mentation. Mentation is a weird word, I understand, for some, but mentation is basically a combination of mental health and cognitive function. So the goal with mentation is to prevent, identify, treat, and manage the 3 Ds: dementia, depression, and delirium across all care settings. And then mobility focuses on ensuring that older adults are able to maintain their independence and autonomy and be able to get around safely. I want to first introduce you to my incredible team before we get into sort of the details. I mentioned before in terms of Steve's legacy and the image of long-term survivors. My project manager is Greg Bruckno, who is coming to us from GMHC, and he is a long-term survivor. Our clinical supervisor is CM Bennis, and she is an occupational therapist, and I want to discuss why that is really important. And our patient navigator extraordinaire is the world famous Michelle Lopez, who, again, I was able to scoop up from GMHC. I'm very lucky. We have an interprofessional team that also includes our clinical HIV clinical pharmacist, Dr. Douglas, our nutritionist, Jackie Brockman, and our mental health behavioral health director, Michelle Melendez. So what I've changed, our focus following the 4 M's, we're going to, in our iteration of this project, we are focusing on functional impairments, trying to identify those physical, cognitive, social, and role impairments that increase the risk of falls before they manifest into disability, hospitalization, and other poor outcomes. Why occupational therapists? Originally, the position of clinical supervisor was supposed to be filled by either a doctor or a nurse. And I advocated really strongly that I wanted to use an occupational therapist. And the reason why is that occupational therapy, that their guiding principles are consistent with the goals of geriatric care in terms of helping individuals maintain independence and the best quality of life as possible. At SUNY Downstate, we are a medical center. We provide a variety of medical health training, including occupational and PT, and to a certain extent, they're really an underutilized discipline around aging. I have long been making an advocate. This is a quote from Berg's paper on the effectiveness of peer support, of the importance of including peers on the team. And that was something that was really important. So both the project manager and our navigator are both individuals aging with HIV. We have swapped out a number of the measures. The MoCA is just not effective, and we are using the mini cog with a picture memory impairment screen. There are also, sadly, a number of real standard measures that should be included in geriatric assessments that were not included in the 5 core measures, such as anxiety, sleep, social support, loneliness. Our nutritionist is doing the nutrition stuff, social determinants of health, elder abuse, the FESI, which is a fear of falling, and we have a dementia scale where it's appropriate. And then finally, in the grant, it was really crazy. They were recommending doing Zumba. And I remember looking at the RFA and just saying, oh my goodness, these folks cannot do Zumba. They will be in the emergency room. And so I have found a really wonderful program called Aging Backwards. It's part of Eccentrics, and it incorporates elements of Tai Chi. And honestly, like right this very second, my team is probably struggling with trying to get our chair class going right now. We also significantly upped our clinical assessments for fall risk to include a geriatric systems review in terms of sensory. We also, in terms of our fall risk assessments, we're doing the tugs. I'm sorry, I don't know why we have the dynamics balance, but we're doing the tugs and the functional research reach test. And of course, GATE. This is our workflow. We identify cases, conduct assessments, analyze data, and develop care plans, implement the care plans and track referrals, and reassess at 6 and 12 months. This is just in terms of our weekly aging class in 2 formats, and that we have a weekly healthy aging education seminar that's linked to the 4 M's. Monthly affinity groups, and we are planning a walking group and an excursion to a new sex positive shop in Brooklyn. I am excited. These folks are awesome. We're also leveraging a lot of local resources, including the Fort Greene Council's adult daycare program, which is a virtual daycare program that runs from 9 to 3 o'clock every day. The Bridge program, we're doing outreach there once a month to do lectures or presentations on pediatric related topics such as dementia, Alzheimer's, etc. So now I'd like to just sort of share with you what's going on in terms of our data. This is just data from our year 2, which started in March. So we have Christmas. I'm so sorry. I totally did not put our N. I believe we have 64 individuals, and the mean age is 62. The majority are, no, that's not 64. What is that? That's 59, excuse me. So in this sample, because I'll tell you why we might have 64, but we haven't been able to finish all of our assessments, and that's one of our challenges. We have in our sample of 59, 46% are women, 74% are Black, either African-American or Afro-Caribbean, and 59% self-identify as being heterosexual, 34% live alone, and 40% are single. Since March, we have implemented or started 4 new individuals on iArt. We've had 3 HIV care referrals. We've conducted, or not us initially, but we have facilitated 71 STI screens, 80 syphilis screens, 79 Hep C screens. We've conducted a whopping total of 417 assessments. We've developed 40 care plans, held 40 case conferences. Our navigator has accompanied thus far 10 people to critical appointments. I don't know if we did our sit chair class today. I hope so, but by tomorrow we will have implemented at least 2 classes, 11 education classes, and this afternoon we'll have a whopping total of 5 affinity group meetings. Our mean scores. So these are the mean scores according to the 5 core. I don't know why quality of life is grayscaled here, but the mean score for PHQ-9 was 5.1, which is mild leaning towards moderate depression. There's a very, between minimal and mild depression is common. Large independence in terms of our mean is about 6.4. Mini HUG score is about 4.3, which is right at that cutoff in terms of needing further assessments. Morse, the majority of our participants have a low to approaching high risk. High risk would be over a score of 50. So most of our participants have a low risk of falling, but it is severe. Quality of life is shockingly low. The mean is about 50.4. Over what the average for sleep with the PSQI, the cutoff is anything over 5 is considered a significant sleep disturbance. So to me, I feel like this is a huge finding, the fact that there's a high burden of sleep disturbance among our population, mild anxiety, minimal loneliness, social isolation. This is with the Lubin social support scale. Not a lot of elder abuse, but that people are also rather high functioning in terms of IADLs. This is a cross-tab by gender. I hope this table is not terribly confusing, but I tried to put both the score and its interpretation. This is an extremely small sample, so we found a lot of significance in the fact that there are huge gender differences between a lot of these scores, and that we're seeing that even though there are more women in this study, but also women are having more severe results in terms of severe depression, moderate to severe depression, moderate depression, etc., whereas the majority of men have minimal depression. With ADLs, we see a lot of independence, and I think this is and with the mini-cog, also that there's a higher level of women who are requiring neurocog assessments, a higher level of high risk for falls among women. And if you can see this number in terms of the high level or the disparities between women and men with sleep problem. I believe this is also driven by the menopausal transition, the fact that a lot of these women are also still experiencing nocturnal hot flashes and other variables at night, as well as nocturia. There are gender differences also in terms of anxiety, women having more mild to moderate anxiety compared to men. Loneliness, we see that sort of loneliness, although this is a small sample again, that we're still seeing sort of this trend in terms of women having more severe levels of loneliness from mild, moderate to severe. Isolation, that again, the majority of women are at risk for social isolation, and that but that not surprisingly with IADLs, that there's a higher function with women. IADLs tend to score a little bit higher for women because a lot of men, and this is gender sexist kind of norms, that a lot of men are not cooking and preparing their own foods. So our challenges, we've encountered challenges implementing this study based on just due to organizational challenges at SUNY Downstate, implementing and adopting these approaches. Sadly, and I did a baseline assessment on geriatric knowledge and skills with our providers. And there is a high level of unconscious incompetence in the fact that our PCPs really think that they are doing or are implementing geriatric care principles, and they're not. A case in point, again, prescribing depends instead of actually sending them to urology or gyno-urology. We have staffing issues and they're everywhere, and it is creating a lot of problems in terms of referrals and getting people in a timely manner to be able to do these assessments. And then finally, what is probably happening right now in terms of communication inequalities, being able to do a lot of our programming virtually, we're faced with communication inequalities and the fact that older adults tend to have lower illiteracy and technology proficiency, as well as just access to not just the smartphone, but also to have a data plan that's able to enable them to Zoom whenever they want to. And finally, one of our biggest challenges, and I'm not sure if Greg will be here, that the structuring of our eShare sequence from DOH we discovered was not feasible in a real world setting. I'm really happy to report that DOH, our technical assistance crew, they listened to us. They called us back in, and as a result, we were able to make changes in terms of how we log in our eShares in a manner that will not create a bottleneck. And this is going to help improve like the eShare sequencing for all of the sites. So congested. So in conclusion, fall risks are high, and I suspect that they're largely driven by the combination of poor sleep and cognitive impairment. Participants are overwhelmingly eager to participate in these resources. It takes a while to convince people and to get them to understand this is not a study. These are services. And then once they are engaged and they get to meet the lovely Michelle and they realize that they actually finally have someone who will advocate for them, they are eager. But there are a lot of people who are proactive, and then there are a lot of people dealing with challenges. We had one participant who for the last couple of months has been spending all of his time in the hospital because his brother is hospitalized. And as a result, he just doesn't have the space to be able to take care, to finish some of the assessments and to let us help him. The most common referrals include, of course, neurocognitive assessments, sleep studies, and pelvic floor assessments. And I just want to say incontinence has emerged to be a larger barrier to social engagement than we anticipated. And fortunately with the WISE, with the combined cohort, this is actually an area that I'm working on a subgroup around incontinence. So I'm eager to look at that. I need to acknowledge, I thought it was going to come up with the VIF team first, but my incredible bridge team. I am part of an age-friendly leader initiative at the hospital, the University Hospital Downstate. And so these are my champions. I'm the champion for what matters. My HIV posse, I still put Steve there because I'm still in denial that he's not with us. And my incredible colleagues at the Center for Positive Living. I've been doing a similar project with Dr. Anjali Sharma, and working with the team with Amanda Perez and Gabriel Ryan. It's been an absolute pleasure working on that project. My CCS combined cohort, WISE Max team, and the BIF team, Tiffany Hong, Evelina Rossi, Julianne Bell, who was at one point my research assistant for my first pilot MIK, who as a result of being project manager for my study on aging in HIV. She is now a director at DOH on the Aging in HIV initiative, which makes me incredibly proud, and Kathy Liu. I just want to mention that sort of Anjali Sharma and my team at the Center for Positive Living, we have an upcoming presentation at the HIV and Aging workshop, and I'm excited about that. And I just want to say thank you. I don't know if I've gone over too long because my head's a bowling ball. And
no, you did great, Tanya. Thank you so much for that presentation, and thank you to you and your team for this critical work. We'll jump into the questions. A reminder to the attendees, if you have a question, you can use the raise hand feature and I will unmute you, or you can type it in the chat and I will read it on your behalf. First, we have a question from Claude. Claude, go ahead.
Hi, Dr. Mellons.
Hi, Tanya. I miss you too. And you're making me feel very old when you said that you've been doing this work for 24, 25 years. I was like,
no. That's just my qualitative field stuff. No.
But I just, like Kate, when you were talking about feeling proud about your RA, I think many of us, after listening to you and Kate today, are just feeling incredibly proud and humbled by the incredible work that you're doing. And so I do have a question besides just saying that was really wonderful. And I won't talk about how much I was applying it to myself.
Well, I'm an older adult. When I started this whole thing, I was perimenopausal, and I remember, because my initial K focused on aging and menopause and sexual health, and I remember I kept telling the ladies, like, in a couple of years I'm going to be with you. And so I am an older adult. I'll be 55 at the end of October.
All right, I won't go there. I won't go there. But so my question is, a lot of what you're describing are huge issues for the general population and a systemic issue. I have a 92-year-old mom, and the lack of geriatricians is huge in every field. So I really commend the work you're doing and hoping that your groups can really advocate using HIV as a model, because I think that often happens for the general population. But my question is a little bit different, although you could talk about that too. I have an aging cohort of, children who were born.
They're also part of that aging with HIV.
They're now in their 30s. And I'm just wondering, if you have any thoughts about the lessons learned from some of this work for younger people who are now aging.
That's a really great question. And thank you, Dr. Mellons. They are actually considered part of, and I didn't operationalize sort of who are older adults, obviously long-term survivors, but it also includes folks over 50 who've been newly diagnosed and sorry, my brain's not working, but it also does include are, perinatally infected young folks who are no longer young. They are in their 30s and they are having, dealing with a lot of these challenges as well. And so I think that we need to include them in that conversation and to realize that sort of, on a cellular level, their body has been aging in ways that doesn't necessarily match their chronological age. And so that we need to be cognizant of these health challenges that may be happening. I also want to say that my work with a bridge is not with an HIV positive population. And so dealing with, my grandmother passed a couple of years ago who was 101, and dealing with her care and managing her care with my mother, I feel like I was really born to do aging work, and that I am eager to do this work with both, aging and health disparities with people who are seronegative, as well as like to use and to really get our community to understand that there are really important lessons to be learned from what's happening with the people who are positive in aging, and that we need to prepare now our workforce to be able to understand how to be able to take care of our older adults.
Thank you.
So go Bridge. By the way, Bridge, we have a didactic every Monday, 3 to 4, 4 to 5, and we have a Bridge Echo to discuss aging cases. And I have been given permission to develop an HIV and aging case conference. And so stay tuned. I'm hoping that this will include all of our partners around New York City, Ginny Siegler at Cornell, Anjali at Einstein, and hopefully you guys at Columbia.
That's excellent. Thank you.
Thanks, Claude. We have a comment and question from your mentor, Susan Tross. Susan writes, "So great to see and listen to you. Thank you for yet another public health significant initiative with people in high need. This has always been the focus of your work. A comment, this is research, although you said not, that can illuminate important services for implementation lessons. A question, is there any room to use resources for home or field visits, for example, for assessment, or to supplement minutes on phones or devices? Feel better."
Oh, thank you. Well, home visits and home assessments are a part of the geriatric assessment, especially around fall risk prevention. Going into the homes, doing home assessments to try to figure out, why are you falling in the bathroom? What home accommodations need to be made, etc. So that is actually something that our clinical supervisor does in terms of self-report, but then our patient navigator goes into the home. There are a lot of patients that are very nervous and apprehensive about people coming into their homes, but if anyone knows Michelle Lopez, she is amazing in terms of developing rapport and trust. It's been sad to also find out that a lot of them are also fearful around the stigma that they might have home attendants that don't know about their serostatus. And so we have been walking a fine line in terms of doing, bringing also the assessments to the homes, making sure that we protect people's confidentiality and to make them feel comfortable. And yes, we are doing a lot virtually in terms of telemedicine and virtual assessments. In fact, most of our assessments are conducted over the phone or using telehealth.
Thanks, Tanya. We may have time for one more question. We have a question from, oh, Fran, did you have a question?
Yes, I do.
Oh, Dr. Kronos.
Hello, how are you? First of all, I just want to say I love the Star Clinic. You know, we as and the NICA ATC is very involved with you guys.
It's a really wonderful clinic. I mean, we're stressed like all the other clinics, but very good to hear from you.
But I just want to say, as a person who is 22 years older than you, I listen to these talks about aging, and I think about how it applies to someone who's really aging like me. And I would never personally go to a physician or a provider who wasn't interested in my mortality. And I noticed that in the discussion of comorbidities, mortality is totally left out, as it is on the HIV care continuum, which is why I think older people are abandoned. If you're virally suppressed, there's nothing more to say. And I wonder what your thoughts are about moving away from our obsession with the HIV care continuum and viral suppression. At this point, only 20% of people with HIV are dying of HIV. 80% are dying of something else. And even though I know we're very focused on, you know, living with comorbidities and how to manage them, when you leave out mortality, you don't get a realistic idea of what the risks are. So I have found this personally very frustrating, and I'm wondering what your thoughts are about it.
Oh, yeah. So I want to say embedded within the 4M what matters is an attention to sort of long-term care preferences. So we do a lot of, and you know, and there's so much cultural stigma talking about wills and advance directives and so forth, but we're really trying to frame it sort of like if you had an accident tomorrow, as opposed to when you are unable to take care of yourself. And I think that what you are also really talking about is, you know, the frustration within, you know, the HIV care continuum is like, we get people to virally suppress and it's like, see you later. And whereas we're not thinking about quality of life as we age and quality of life at the end of life. And so I think you're absolutely right. I think the focus within HIV primary care is not taking into consideration of that. And I think that sort of, you know, I think of my mother who is your age, and thinking about sort of, you know, her as an aging older adult. And, you know, my mother would fight you right now if like anyone called her geriatric. And she's retired and busier than ever. But, you know, like we have lots of conversations and we've had conversations in terms of quality of life and care preferences and thinking about comorbidity and thinking about, and, you know, within sort of our model, maybe this is a better way. I really apologize if my brain is fuzzy. Michelle Lopez and I developed an intervention called Healthy HIV Aging, where we implement this in our education program every week, where we focus on five components: strengthening resilience, you know, sustaining viral suppression, being proactive in terms of prevention, my brain's not working, being proactive in terms of promoting prevention, you know, addressing risk behaviors and social engagement. So, you know, the being proactive and thinking about, I didn't have a lot of room with my slides, but there's a lovely image, book that was published by Acrea that, you know, has Michelle Lopez as the cover girl, that talks about all of these things, you know, in terms of all of these comorbidities or HIV related issues such as neuropathy, or, you know, in terms of, you know, the additional risk in terms of cardiovascular disease for older women. So, you know, we spend a lot of time trying to do just basic health education, to have people understand, you know, that it's never too late. You know, it's never too late to stop smoking. Even, you know, cutting back on your cigarettes today is going to extend your life. And so we spend a lot of time thinking about corrective and proactive health education. And I think that, you know, honestly, at a medical center, you know, I'm saddened by the fact that we don't have a preventative medicine department where we can really focus on these things. We have a health fair this weekend where we're going to be doing screens around fall risk and around COVID and so forth. But I feel that that's really lacking, you know, really thinking about looking at whatever comorbidity you have and trying to be strategic and plan for the future in terms of managing your comorbidities. Did I answer your question? Not really.
I think you did. We're at time. Thank you so much, Tanya. Bob, I'll turn it back to you.
Okay,
you.
thank you, Stephen. Thank you, everyone. Thank you, Dr. Taylor and Dr. Elkington. As Claude and several others have said, we're very proud of you, and we're very pleased and blessed that you were with us today and showing us the really wonderful work that you're all doing. So yeah, we're over time. Just a reminder to everyone about our second in the series of our behavioral interventions, why they work and don't work, on October 4th. And then 2 days later, our HIV rounds with Florence Montplaisir, and October 20th with our fellows, Red Driver and Ohema Poku. So have a good day, everyone. Be well, and hope to see you at our next seminar. Take care. Bye.